Assalamu alaikum. I got the order to start, so I have to start. So I'm going to talk about, again, you have to listen to me whether you like it or not, okay, about the principles of mechanical ventilation. Only principles of mechanical ventilation. You know, this subject is a very big subject, and if we can just grab whatever I'm going to say, you will have some idea about mechanical ventilation. So normally what we are doing when we are doing breathing or ventilation, spontaneous breathing, we contract our respiratory muscles, so the chest wall will be expanding and the diaphragm will go down. This will create negative pressure within the pleural cavity, and this will suck out the lung outward. This will create negative pressure within the airways. So during inspiration there is a negative pressure less than that of the atmospheric pressure, so the air will gush or will follow into the lung, okay, and then when the pressure inside the airways will be increasing from negative, it will go back again toward the zero. Once it reaches zero, the expiration will start, because here the lung will start to recoil in the chest wall and will push the air within the airways out into the atmospheric pressure, because the pressure here in the airways will be higher. So during inspiration we are inducing negative pressure within the airways, and then because of the recoil of the lung and chest wall, this will force the pressure outside. So only the inspiration is active process, but the expiration is a passive process. Active in terms of energy, you don't need energy to expel the air out, but you need energy to take the air in. So if there is, during inspiration, if there is negative pressure within the airway, we call it negative pressure ventilation. Now, can we do that mechanically if the patient cannot expand the chest wall? Like, for example, respiratory paralysis, okay. Can we do that the same way? We can do it in the same way, yes. If we apply something on the chest, we wrap the chest with, say, a pillow with a vacuum within, 2 layers, and then we create negative pressure. This will suck the chest outward and will produce the same process, okay. So if we are doing this mechanically, we are doing it normally, spontaneously. If we do this mechanically in a patient who is, say, paralyzed, we are doing what's called negative pressure ventilation, but this is mechanical, okay. So the first attempt of respiratory resuscitation by mechanical ventilation was actually to simulate the normal physiologic mechanisms, but this need a big machine that will wrap the chest wall, and you need a big space, and it's difficult to care about the patient, although there are new advances in this regard. So the initial attempt of mechanical ventilation was to simulate the normal physiology, and the process is a negative pressure ventilation. Now, if I can push the air directly into the airways, so during inspiration there will be a positive pressure, actually not negative pressure, and this will inflate the lung and expand the chest wall and push the diaphragm down. So it's the opposite process. So I started during inspiration with positive pressure. This is called positive pressure ventilation, okay. So if you are inducing the inspiration by negative pressure in the airway, this is negative pressure ventilation. If you are pushing the air directly into the airways and inducing positive pressure during inspiration, this is called positive pressure ventilation, okay. Clear? You follow me? That's the name. I'm just explaining the name of positive pressure ventilation and negative pressure ventilation. Okay. Now, when do we need mechanical ventilation? If there is failure of the normal spontaneous ventilation, whether it is mechanical or oxygenation failure or paralysis or obstruction or whatever the mechanism is, we need to do a mechanical ventilation. If the patient cannot use his lung, or there is a barrier for the oxygenation of the blood to take out. So there are many reasons or many indications for mechanical ventilation. If there is a mechanical failure or ventilatory failure, that is, there is accumulation of CO2 like in COPD, or oxygenation failure, that is, if there is pulmonary edema or ARDS, or general anesthesia before surgery because the patient will be paralyzed, or post-cardiac arrest if the patient is unconscious and there is no drive for respiration, or whether it is due to drugs or whatever. So, what are the types of mechanical ventilation? In terms of technique, there are two types, either negative pressure ventilation or positive pressure ventilation. And the positive pressure ventilation is either non-invasive or invasive. What we mean by non-invasive and invasive, invasive is that if there is an artificial airway. So if there is an endotracheal tube or tracheostomy tube, this is called invasive positive pressure ventilation. If we are using a mask and we are using the normal airway passage of the patient, this is non-invasive because we are not producing or we are not introducing any tool into the body. Okay. So positive pressure ventilation is non-invasive and invasive. I'm going to talk about the invasive first, and at the end we'll talk about the non-invasive. This is the negative pressure ventilation, and it started in 1928 in the United States using this type of machine. And you can see how the ICU was like. It's a big hall, and there are many chambers in this hall, and you can see the nurses how they are moving between the chambers. You can see only the patient head can be seen through this chamber. This is more detailed structure of this chamber of negative pressure ventilation. Only the head of the patient can be seen, and the remaining is the hall, and you cannot take care of the patient properly. This is more advanced, the same principle, but you can see the patient through a glass. But in all this negative pressure ventilation, you need the normal chest wall and lung, otherwise you cannot use it. It's more advanced now with more modification, that is called the chest cuirass. You just apply it to the chest, and the remaining of the body you can see it and the patient can move. Now the positive pressure ventilation is the first used in 1955, and now it is the modern standard of mechanical ventilation, and the era actually of the intensive care medicine began with positive pressure ventilation. So it is the backbone of service in the ICU. Now, when we talk about positive pressure ventilation, we are talking about modes, because the negative pressure ventilation is only one mode. Okay, but in positive pressure ventilation we have different types of modes. We can either move the chest or the airways by pressure only and flow, or by volume directly. Okay, so what is the mode actually? The mode is the type of interaction between the ventilator and the patient. And the major two modes that we are using, whatever the names are, the principles are two things: either using pressure or using volume, or mixture of both, or modified pressure, modified volume, modified pressure and volume, starting with pressure, ending with volume, starting with volume, ending with pressure, but the principle is the same. The principle is that is finally is either volume, you are producing volume into the patient directly, a specific size of volume or a specific tidal volume or minute ventilation, or you are inflating the chest with pressure, and this will drive the flow. Okay, so the principle is the same. It is either pressure cycled or volume cycled. What do we mean by that? In pressure cycled modes, it delivers fixed pressure at variable volume, and in volume cycle modes it delivers a fixed volume and at variable pressure. We'll talk about that or explain it. The number or the type of modes, this can be either totally controlled, that the patient is not doing any form of work of breathing. This is called control. If the patient is doing some efforts, it's called support, okay, or assist. In terms of volume, we say it is assist. In terms of pressure, we say it is support. So either the patient is doing the whole, the machine is doing the whole work of breathing for the patient. It's totally controlled. Okay. If the patient is the one taking all the efforts of press and the machine is only supporting with some pressure or beep or whatever, this is called support or assist. If it is mixed, then it can be assist control or IMV with pressure support or SIMV with pressure support. So you have both. You have controlled breaths, that is totally delivered to the patient by preset values, or the patient is doing an effort and we are just helping him, and beside that he is taking also mandatory breaths or control breaths. Clear? So in pressure cycle, we have pressure support ventilation, we have pressure control ventilation, that is if the patient is not doing effort, and these are mandatory breaths are given to him. And we have a CPAP and BiPAP. And what we mean by BiPAP is actually a B plus C was pressure support. So BiPAP is a B plus pressure support. So that all the time the pressure inside the airways is positive. Okay, but the patient is also spontaneously breathing. So in this, only in control, the patient is totally controlled, that is not doing any effort. In support, in BiPAP and CPAP, the patient is the one who is driving the machine and we are just supporting. In the volume modes, it's either control or assist control or intermittent mandatory ventilation. Again, it's the same, control. Mandatory means control. Or synchronous intermittent mandatory ventilation. Now here again, in intermittent mandatory ventilation, we are delivering certain number of controlled breaths. Okay, and in between the patient is taking spontaneous, totally spontaneous breaths. All right. In assist control, he is taking mandatory breaths, that is the control part, and he can take additional breaths but with the same tidal volume I'm giving it. Okay, so that's the difference. In assist control, he is taking mandatory breaths, say 10 breaths per minute, and he can take additional if the patient can. And these additional breaths will be assisted by the same tidal volume. Say I put him 500 ml of tidal volume per breath and 10 breaths. If he's taking say 15 breaths, he will take all the 15s are assisted only, not controlled. If he go below 10, then all the breaths will become controlled. You get it? Okay. Alright, so in synchronous and mandatory, it is the same as mandatory ventilations. Here the patient, between the breaths, he can take spontaneous breaths with his own parameters. Okay. In synchronous, the mandatory breath, if the patient is doing a breath just before that mandatory breath, that breath will be synchronized to the patient effort. This is the only difference between intermittent mandatory ventilation or mandatory breaths and the synchronous. Synchronous, that means within what's called the SIMV period, that is before the mandatory breath. If the patient did any effort, that breath will be pushed forward or it comes before its actual time. Clear? Okay. Now, what are the advantages of pressure and volume modes? In pressure modes, we have variable flow, that is, the patient is more comfortable, because if the patient has a stiff lung or chest wall and the flow is constant, that is in the same rate, the patient will not be comfortable. Okay, so the variable flow makes the patient more comfortable. So during pressure mode, the patient is more comfortable and better, you need less sedation. And we have the pressure of the airways and the pressure of the alveoli is controlled. That means at that pressure, when you reach that pressure, the ventilator will cycle. What we mean by cycling, that it is pressure cycling. That means if I reach that target of pressure I set for the patient, the ventilator will cycle to expiration. That's the meaning of it. So cycling is the event that when it reach, or the goal that when it reach, the ventilator close the inspiratory valve and open the expiratory valve. Clear? So cycling is the transition or the parameter that determines the point at which the ventilator will change into the expiration. Okay. So if I reach a pressure, if I did a pressure cycling ventilator and I put a pressure say of 20, once that pressure is reached, the cycle will go to the expiration. Correct? Okay. Now in a volume, if I put volume say of 500 ml, once that volume is reached, then the ventilator will cycle. So the determinant of cycling in pressure is, in pressure modes, it's the pressure that when it is reached, and in volume modes is the volume that I preset for the patient. When it is reached, the ventilator will cycle into the expiration. Clear? Okay? Clear? Alright. So the advantage again is that it is better with leak for the pressure. Why? Because the machine has to reach that pressure. Okay. So if there is a leak, it will continue and giving more flow. Alright. So if there is a leak in the patient, the pressure is preferred because it can give you still. It has to reach that level of pressure that you preset for the patient. But if it is in the opposite way, if it is in the volume, if that amount of volume is reached, whether there is a leak or not, it will stop. So this is one of the advantages. If there is a leak, you need a better, or you can control it more with pressure. Now, in volume modes, there is a consistent tidal volume. This is an advantage. Okay. So that volume or minute ventilation that you preset for the patient, it will be delivered to the patient. So you are happy that all the volume that the patient needs will be delivered to him. And you can make sure that the minimum minute ventilation will be delivered to the patient. So I set for the patient 10 breaths per minute or 500 ml, so 5 liters per minute will be delivered to the patient. And I'm sure about that. But in pressure, of course, I cannot make sure about that because it's the pressure which drives the flow. Okay, and if there is any change in the patient mechanics of the lung, and the pressure in the airways is higher, once that pressure is reached, the flow will be stopped. So the patient will get low tidal volume. So this is the advantage. In volume modes, I'm sure that the patient will take that volume, and I'm happy with that. Okay. And the minute ventilation will be delivered to the patient, and that minimum ventilation will be constantly given to the patient. In the pressure mode, I cannot ensure the volume. So, but I know that this patient is protected because he cannot exceed that level of pressure. Clear? So, in other words, in pressure modes, I can control the pressure, so that pressure will not be exceeded, but I cannot control the volume. Okay? And in volume modes, I can control the volume so that this patient will get that volume, but I cannot control the pressure, and he may get problems from increasing pressure in the airways, and maybe he will get air leak or pneumothorax. What are the disadvantages? I just talk about them. In pressure modes, there is variable tidal volume, either too large or too low, and you have to adjust the pressure until you reach that target volume. So continuously you have to monitor the volume in pressure. Okay. So in pressure modes you have continuously to monitor the volume because the patient may go into hypoventilation or even hyperventilation. Okay. Now in volume modes, the pressure is the one which is variable. So in a patient who is ventilated by volume mode, you have to control or to monitor closely the pressure. So these are the two important things. In volume modes, I am sure that the patient is taking enough volume. Okay. In pressure modes, I am sure that the patient will not exceed that level of pressure. Now, in the disadvantage is that in pressure modes, I cannot make sure that the patient will take enough volume. Okay. And in volume modes, I cannot control the pressure in the airways. So each one has advantage and disadvantage, and you have to choose according to the patient mechanics of the lung. And this will be determined also by the ventilator. You can make a lot of calculations and testing on the ventilator and determine what is the best mode or what are the best parameters for the patient to be set. Now, I said we have many types of modes, and every day we hear about new modes, and the engineers are working and the companies are racing in this regard and producing new modes. But the principle is still the same. All of them are either volume or pressure or mixture of this. Okay, and then a lot of manipulations and just to satisfy and make the interaction between the patient and the ventilator more fine and more secure ventilation. This is what's going on nowadays, and they are producing. But the principle is the same. It is pressure or volume or a mixture of this. And so far, all the studies did not show any significant difference in the outcome in those patients ventilated by different modes. Okay. So even those new modes and new ventilators and very fancy ventilators, they are more secured, yes, but the modes themselves and the advances in the modes, they did not show in clinical practice any difference from the old machines and the old modes. Okay, as you can see here, no statistical advantage. Okay, in this inverse ratio ventilation. Here, no mortality benefits demonstrated. Here, there is improvement of oxygenation, that is the high frequency. Only improvement in oxygenation, but no clear or unclear mortality benefits. So, if you are still using the old modes, they are still the principal types of mechanical ventilation used everywhere in the world. Okay, now once you decided that this patient needs mechanical ventilation, you have to do what? You have to do the setting of ventilation and also the setting of security or alarms. Now, setting of ventilation, you first choose what? The mode. And the mode is chosen according to what type of support you need. Is it full ventilatory support? So you will use control mode. If it is partial, then you will use partially supporting modes. So in here you will assume essentially all the work of breathing will be delivered by the machine, and the majority initially requires full ventilator support of the patient. Usually because we anesthetize the patient before intubation, so you need full ventilator support initially, and then after that you will modify according to the patient situation. And here you can use either pressure control or assist control or SIMV. If the rate is high, it will become like assist control. SIMV, if the rate is high, it will become like totally control. Okay. In partial ventilator support, you provide less than total amount of work of breathing, and it's common during weaning. We are usually using these modes, and includes SIMV, pressure support ventilation, and BiPAP. Now, the initial setting in volume limited or volume cycling modes, we set these parameters, FiO2 rate. These are the common parameters, and there are additional parameters according to the mode you are choosing, and for more security. The inspiratory time, inspiratory-expiratory ratio, beep, and tidal volume. In pressure modes, again the same parameters, but here this is the only difference. So in volume modes, the same parameters for all ventilators, but you are concerned here about the tidal volume that should be preset by you. In pressure modes, you are concerned about the peak inspiratory pressure or the peak airway pressure that you should be set by you. And these are different terms used by different companies of the ventilators. So it's here you can either set the minute ventilation, like for example in Siemens, or tidal volume directly, like if you are using other methods. Okay. Now, these are the parameters that you are usually setting and their values. FiO2 usually you start with 100%, and after stabilization we attempt to keep the FiO2 less than 50, because that is 60 or more is the toxic level of oxygen. So all our target is first to stabilize the patient and correct the hypoxemia, and then once corrected you have to go down to less than 60 or around 50, which is safe for the patient. Respiratory rate, the average is 8 to 12 breaths per minute, but you can go up to 34, that is allowed with low tidal volume. The flow rate in some ventilators you have to set it, so it is set at 40 to 100 liters per minute, or 4 to 10 times the minute ventilation. The tidal volume here, there is a lot of talk about the tidal volume. Usually if the patient has normal lung, it is 8 to 12, 8 to 10 ml in a patient with obstructive lung disease like COPD. And in ARDS, and this is the most important, and you should be strict to these values, which is 6 to 8 or 4 to 8. And the best tidal volume that achieves less mortality is a 6. Okay. So in ARDS, the target tidal volume is 6 ml per kg ideal body weight. Or otherwise you go with the minute ventilation, which is the respiratory rate times the tidal volume. The I to E ratio is the time, the respiratory cycle is inspiration and expiration. And usually we set the inspiratory time, because the expiration we set is passive. So the inspiratory time in some modes it has to be set. And we keep this I to A ratio as 1 to 1.5 up to 1 to 4. This is the normal. Actually we are taking up to, it is almost 1 to 2 in the normal spontaneous breathing. Okay, so that is the time of inspiration that we are usually using, is 0.8 up to 1.2 seconds. Positive and expiratory pressure, this increases the functional residual capacity, so you can enhance or improve the oxygenation. And it is useful to treat refractory hypoxemia, initially set at 5 cm, and then we go subsequently according to the ABG by increments of up to 2 per hour, and not more than that, otherwise you can cause harm to the patient. Now, how do we adjust the parameters after setting? If the problem is hypoxemia, then we have these parameters to play with. Okay, it's not the rate or the tidal volume to correct the hypoxemia. It is either the FiO2, beep, inspiratory time, or peak inspiratory pressure. And these three are collectively called, or they can form what's called the mean airway pressure. So if the problem is oxygenation that is still hypoxemic, then I have to increase the FiO2, or adding beep, or manipulating the inspiratory time to shorten it, or increasing the inspiratory time, or increasing the peak inspiratory pressure in some ventilators. If the problem is accumulation of CO2, like in type 2 respiratory failure, and the oxygen is okay, then we will play only with the rate and the tidal volume. Clear, this is very important, you have to keep it in mind. If the problem is hypoxemic, don't increase the rate, he will not benefit from the rate. Okay. If the problem is CO2, don't increase the FiO2, he will not benefit, he will get even more worse CO2 retention. Okay, you got this point. If the problem is CO2 retention, you will play only with the rate and tidal volume. If the problem is hypoxemia, it is FiO2, beep, or respiratory pressure, or mean airway pressure. Okay, clear? Clear? Hello? Hello? Okay. Now, once you got or you did the sitting and you adjusted, you need to keep the patient in a safe situation. And this machine is equipped so that the parameters you put for the patient, you can make a range for them. If this range is exceeded, whether down or up, then this machine will give you an alarm telling you that there is something wrong. Okay, you did this sitting for the patient and they are not in the proper situation. Okay, so these machines are equipped with what's called alarms. If you put a range, say for tidal volume between 400 and 600 ml, okay, or minute ventilation between 4 liters and 10 liters. If it exceeds more than 10 liters, the ventilator will give you an alarm. If it goes down to less than 4 liters, the ventilator will give you an alarm, and it will show you that there is decreased minute ventilation or increased minute ventilation or high airway pressure or so. So you have to go there and switch the knob off and keep comfortable with you. Okay, no. The best is to correct it. Okay. That's the usual habit of us. We first go to the knob and switch it off. And then sometimes you forgot it. And still again it will ring again, okay? And each time you just push it off, okay? Silence. No, the correct way is to go to see why. Because you are the one who put this range, okay? Either you change the range or correct the cause, okay? So we have a lot of parameters that should be adjusted for the alarm setting, okay? You can have high-low minute ventilation, high-low respiratory rate alarm, apnea alarm, low exhale tidal volume. Actually, it depends on the ventilators you are dealing with. And the parameters can be different from one ventilator to another. Alright. Now, the most important alarm that is usually ringing, and about 70% of all the alarms that ring within the ICU, is the high respiratory pressure alarm. Okay, and there are many causes, and these causes can be very simple and corrected by the nurse. And this includes water in the circuit, or kinking or biting of the AT tube. So you have to look at the patient mouth, secretions in the airways, bronchospasm, but can be also tension pneumothorax or decrease in lung compliance, that is stiff lung, and increase in airway resistance or coughing or fighting by the patient. So most of these problems can be easily corrected at bedside and within less than 1 minute. Now, caring of the ventilator and also caring for the patient. So how to care about the ventilator? You should never use the top of the ventilator as your desk, okay, and put your copy on it. And you should never make change to the sitting unless you know what you are doing, okay, because it can be fatal. So if you don't know, then you have to refer to the RT or the medical doctor or the nurse in charge to make the adjustment. And also you have to avoid using the mobile phone close to the mechanical ventilation. There is a recent study stating that if you are using the mobile closer to the ventilator by about 3 feet, it can affect the function of the ventilator. And also you have to record and document the following settings per unit: standard, rate, FiO2, tidal volume, pressure support, PEEP, CPAP, peak pressure, and SpO2 in timely manner. Okay. And again, also not only to care about the ventilator, but also to care about the patient. So you have to provide oral care, BRN, reapply AT tape every 24 hours, and see the size of the tube. Provide trach care if the patient is on tracheostomy tube, and replace the inner cannula every 12 hours, and BRN monitor for complications, suction as needed, and wean and extubate. And also you have to observe and document airway type and size and position, characters of the insertion site, date of the airway inserted, and pulmonary assessment with inspection, palpation, percussion, and auscultation. What are the complications? All of you will say pneumothorax. Yes, pneumothorax is a very common and the most horrible problem, but also the patient can get many other complications, including GI bleeding, polytrauma, barotrauma, decreased cardiac output because of increase in thoracic pressure, and also the patient may die because of disconnection and you don't know, you just switch the alarm off. Respiratory infection, valve, ventilator associated pneumonia, acid-base imbalances, and oxygen toxicity. This is pneumothorax. Okay, so be careful when you look at the X-ray. Look at it first before the doctor and see if there is pneumothorax or not. Now, you started ventilation. The patient continued on ventilation for 1 or 2 or 3 days. Okay, and then this is an invasive procedure that should be stopped. It should not continue forever. So we have to assess weaning every day. Okay, so weaning assessment should be done every day because this is an invasive process and has, as you can see, a lot of complications. How do we assess the patient? And when the patient is ready to wean, we look at the clinical parameters and the numerical parameters. The clinical parameters include resolution and stabilization of disease process. The patient is hemodynamically stable, intact cough and gag reflex, so the patient can protect his airways, and acceptable ventilator setting, FiO2 less than 50, bead less than 8, PO2 more than 75, and the pH more than 7.25. And also we have a numerical parameter. This is the BF ratio, which is the PiO2 divided by FiO2. It should be more than 200. Tidal volume more than 5 ml per kg, respiratory rate less than 40, vital capacity more than 10 ml per kg, and minute volume less than 10. And we can do these 2 tests on the ventilator itself. Usually it's done by the RT. These are the NIF, or the negative inspiratory force, and the RSPI, or the rapid shallow breathing index. The rapid shallow breathing index is the respiratory rate divided by tidal volume in liters. So if the patient has a NIF more than -25 or a rapid shallow breathing index less than 100, then the patient may be ready to wean. What are the weaning processes? We are using these 2 modes for weaning. Either SIMV, pressure support, or spontaneous breathing trial. The best one, which shows short duration from the time of weaning until extubation, is the spontaneous breathing trial, and the average is 2 days. So if you follow this, the average is 2 days. If you follow the SIMV, the average duration until you reach extubation is 5 days. This is by one of the studies. In pressure support, it was 3 to 4 days. Okay. Now what is the spontaneous breathing trial? Spontaneous breathing trial, you put the patient on sitting down. The patient is ready to wean. You check all the parameters. You put the patient on spontaneous breathing trial with a beep of 5. Pressure support of 0 to 5, FiO2 less than 40, and breathe independently for 30 to 120 minutes. And do ABG. And then monitor the patient for these parameters. Okay. And if any of these parameters occur, then this patient has failed. Okay. This trial, and we will see in the next slide what we are going to do. So if the respiratory is more than 35 for more than 5 minutes, SO2 less than 90 or less than or more than 30, heart rate more than 40, systolic blood pressure more than 80 or less than 90, or sustained increase in work of breathing by using respiratory muscles, cardiac dysrhythmias, or the pH drops down to less than 7.32, this patient failed the spontaneous breathing trial. What we will do, we will follow this protocol. Actually, this protocol can be different from a hospital to another, but this is a standard protocol. You are doing mechanical ventilation for the patient, and you find that the patient is ready to wean. Okay, so you shift the patient to rapid shallow breathing index, and if the shallow breathing index is more than 100, then you go back again and do mechanical ventilation for another day. If the rapid shallow breathing index is less than 100, then you will do spontaneous breathing trial. Okay. Now, if the patient did not show any failure parameter, then you will extubate. If any parameter is shown of the failing parameter, then you have again to go back for another 24 hours of mechanical ventilation and attempt spontaneous breathing trial in the next day, but not in the same day. So not more than 1 spontaneous breathing trial per day should be used. Okay. Now again, finally what you are doing, you finish, the patient is ready to wean, and you did spontaneous breathing trial, the patient is okay, you will do what? You will do extubation. And of course, you know the extubation, you have to follow the sequence, explain the procedure to the patient, RT must be at bedside, should be careful about the patient, wash your hands, section airways, place a tool on the patient, assure new oxygen setup is ready to use, deflate the cup, apply supplemental oxygen, monitor for distress, and keep ready for intubation. Or in a patient who has COPD or pulmonary edema, you can use BAP directly after extubation. Now finally, we'll talk about a few words about the non-invasive positive pressure ventilation. Okay. Now we said non-invasive if we are not using tracheostomy or endotracheal tube. And it has advantage and disadvantage. The advantage is that it allows the patient to maintain normal function, speech and eating, helps avoid the risk and complications related to intubation, sedation, and less ventilated associated pneumonia. But it has also disadvantage that less airway pressure is tolerated. You cannot exceed 20 or 25, and does not protect against aspiration, and there is no access to airway sectioning. So it has advantage and disadvantage and not suitable in all patients. Now, what are the indications of the clinical use? It is the commonest or the most important two situations for and the approved of benefit are two: the COPD patients and patients with pulmonary edema. But also there are other. It can be used in mild hypoxemic respiratory failure and in other possible indications like weaning, I just have said, obesity, hypoventilation syndrome patients deemed not to be intubated. The patient does not want to get intubated, post-surgery, and in case of asthma. What are the contraindications? If the patient cannot protect himself, if the patient is in respiratory arrest, he cannot breathe, and if there is severe encephalopathy with GS less than 10, severe upper GI bleeding, the patient may aspirate, hemodynamic instability or unstable cardiac arrhythmias, facial surgery, trauma and deformity, you cannot apply the face mask, upper airway obstruction, inability to cooperate and protect the airways, and inability to clear respiratory secretions. How do we use it? How do we initiate the negative respiratory pressure? The initial setting includes spontaneous trigger mode with pack up rate. Actually, the new ventilators, they have also modes to apply bibarbonate. Okay, so you start with low pressure and IBAB, which is the pressure support of 8 to 12 and a beam of 3 to 5 centimeter H2O, and then adjust and spark O2 to keep O2 saturation of more than 90. That is the first parameter, or to correct the hypoxemia. Then you will increase the IBAB gradually up to 20 centimeter as tolerated to achieve these goals. The goals of non-invasive pressure ventilation is to alleviate dyspnea, decrease respiratory rate, increase tidal volume, and establish patient ventilatory synchrony. Okay? So you have to read and read. And you should have a teacher to help you at the beginning, but not like this guy. Do you have any questions?